Yeah, I need to let everyone know that we're being recorded. I hope you're okay with that. A lot of people have asked me to go over like renal stuff, and I think the thing about renal that confuses a lot of people is like the really like weird like glomerular nephritis kind of things. We're not going to talk about that today. We can do like a quick session on it, but honestly, it just doesn't come up in your exams a lot. It's super niche. No one really understands them except for like renal physicians. I put a little bit about them in here, but as I said, they just don't really come up in your exams that much. So we'll go over some more common stuff that will come up. So to start off with, this is Mr. Lim. What are your thoughts about his blood tests? So what are the most obvious abnormalities? Yeah, so you've got a high urea, got a high creatinine, and you've got a high potassium. So what are you worried about now? Yeah, so this is, yeah, you're worried that this is an acute kidney injury. Exactly. And we'll come back to this in a minute. There is a more pressing concern for Mr. Lim than AKI. And what was that? What's the most concerning thing about those blood results? If you had to pick one. Yeah, hyperkalemia, exactly. And hyperkalemia is extremely worrying because it causes life-threatening arrhythmias. And we'll quickly go over the management of hyperkalemia. So I like to split it up into 3 things. So investigate, stabilize, and then treat. So what investigation would you, I mean, I kind of accidentally revealed it, but what's the investigation you want to do for hyperkalemia? Yeah, ECG. And what sign are you going to be looking for on the ECG? What's the earliest sign you'll see? Yeah, tall tented T waves are the earliest sign, and then later on you might see widened QRSs and other like distortional things. But yeah, tall tented T waves is like the first sign of hyperkalemia. And if someone does have that sign, you're going to go on and you're going to have to start like your protocol for managing hyperkalemia. So the first thing you want to do is stabilize the patient. What drug in particular do you use to stabilize patients when they are hyperkalemic to prevent them from getting worse? Yeah, calcium gluconate. And what that does is it stabilizes the myocardium. Specifically to know, this does not affect how much potassium there is in your bloodstream. It only stabilizes the myocardium, doesn't change anything else. But then you treat the hyperkalemia itself. And what can we use to treat that? So yeah, insulin is one of the things we can do, and the other less commonly used thing that I've never seen yet is salbutamol. And both of these drugs work by moving potassium from the blood, which is the extracellular space, into the cells. It's very important that we give dextrose with the insulin. Why is that? Yeah, exactly. You don't want them. Yeah, you don't want them to get hypoglycemic, precisely. And then a few people in my year used to asked about this in like our revision lectures at the end of the year, because PastMed talks about them. So the calcium resonium is something that you can use to reduce the amount of potassium in the blood, and like it's not used in an acute setting though. It's used like if someone is like chronically slightly hyperkalemic, you might want to use calcium resonium. And in an AKI, if you cannot fix their hyperkalemia due to using insulin or using salbutamol, you're probably going to end up dialyzing them or filtering their blood. And hemofiltration is something they can do on ICU. So if they're really ill, you can send them to ICU and they can stop that from happening. But yeah, so acutely you do not use calcium resonium. It's just a thing that PastMed likes to throw out. I've never seen any patient ever use. I've never seen a patient on calcium resonium. Okay, fine. So if we go back to AKI now, what's like kind of what is AKI if you have to summarize it for like a layman? If I knew nothing about medicine, what would you tell me? Yeah, so it's like a deterioration in kidney function in the range of hours to days. I think, yeah, officially it's like less than 90 days. Anything more than that is considered chronic kidney injury. But yeah, it's a bit of a weird definition that's not actually that useful. And then like we can stage AKI using these. I think you can use these are like the two things you can use. How is hemodialysis different to hemofiltration? It's not. It's not a stupid question at all. That was a question I knew the answer to last year. I think with hemodialysis, you have the two solutions. You have one, you have the blood, and then you have this dialysis solution, and the concentration gradient for each of these between the two solutions allows us to filter out certain chemicals, and you change the dialysis fluid in order to change what you're filtering out. Yeah, exactly. And then hemofiltration, you're literally putting it through like a chemical filter. It's not based on a concentration gradient. Do you use loop diuretics to remove potassium in the end? I think you can, but like I've never seen it used. I mean, loop diuretics are a classical cause of hypokalemia. Yeah, exactly. Hemofiltration is not long term. You dialyze long term, but then that just becomes chronic kidney disease. Yeah, hemofiltration is something that's very commonly done on ICU. So AKI staging, you can either use urine output, which is a bit easier to get clinically, or you can check their baseline, how their creatinine has changed in relation to their baseline creatinine. Why is it important that we use the baseline for creatinine? What kind of things can change a person's creatinine level? Yeah, so muscle mass is like muscle mass is the biggest thing that varies. The other thing is ethnicity. Certain like I think some labs correct for certain things. I can't remember which things they correct for. I think PastMed accounts for it. Age, yeah, it really depends on the lab. You just go with PastMed. I don't know what they adjust for anymore. And then we go on to the interesting bit of AKI, which is like the different causes of it. So if you had to split this up, just like we split jaundice up, how would like functionally, how would you do it? Yeah, pre-renal, renal, and post-renal is the way you do it. And splitting stuff up just makes it a lot easier to remember generally. So if you had to summarize each of these causes, so what is pre-renal AKI? For those of you who've done renal. If you had to summarize pre-renal AKI. Yeah, so it's reduced perfusion of the kidneys. It's effectively like a heart attack or a stroke to the kidney. That's what a pre-renal AKI is. Then a renal AKI is an intrinsic problem that causes inappropriate filtering. And then post-renal is always obstructive. So if you just remember those are like the big groups of causes, we can then delve into those a little bit deeper. So what are the two big groups of causes of pre-renal AKIs? So renal artery stenosis is one of the big groups. Sepsis isn't one of the big groups, but it's one of the bits of the big group. Okay, so you've said hypovolemia, hemorrhage, and dehydration. What are all of these examples of? Shock, exactly. So, and Arnab went over this a couple of weeks ago. So the two big causes are shock and renal artery stenosis. We'll talk about renal artery stenosis first because we haven't been over that. Does anyone know what the triad is for renal artery stenosis? There's a triad of features. Because medicine is just lots and lots of triads. So uncontrolled hypertension is one of them. We are talking about kidney injury. So kidney injury is the other one, and then they also get this thing called pulmonary edema. Yeah, it can be AKI or CKD. It is more likely to be CKD because 90% of cases are due to atherosclerosis. But there's 10% of cases that are due to fibromuscular dysplasia. It occurs in more likely to occur in females. And these people, when they're started on some renal affecting drugs like ACE inhibitors or anything, they suddenly deteriorate and they get an AKI. So if you're going to remember three things, you get a kidney problem, you get uncontrolled blood pressure, and you get flash pulmonary edema. So while we're on pulmonary edema, there's a good acronym for the causes of pulmonary edema on a chest X-ray. Not causes, for the features of pulmonary edema on a chest X-ray. Does anyone remember what it is? Yeah, ABCD, precisely. So what does A stand for? You have to use your imagination a little with most of these. That's actually pretty bad. Yeah, alveolar shadowing. And if you can see on this chest X-ray, the shadowing is towards the hilar regions, and then it's worse in the lower lobes than the upper lobes because of the way gravity works. Okay, what does B stand for? Yeah, curly B lines, which are almost purely academic. So breathing lung fields is so you also use ABCDE as an approach to any chest X-ray, but this ABCD is just specifically for pulmonary edema. What's C? So C exists in this one, but it wouldn't normally exist if it was due to renal artery stenosis. Yeah, so it's cardiomegaly if it's secondary to heart failure. D? Yeah, D is upper lobe diversion, and I didn't actually know what this was until the end of fourth year. So if you look at the vessels towards the top half of the lung fields, they almost look leaf-like and branching outwards. That's what upper lobe diversion is. If you look at a normal one and compare it to pulmonary edema chest X-ray, then you might be able to tell the difference. It's quite a subtle sign though. And then what's E? What's P? What's E? Sorry, not P. There's a clue there. Yeah, effusions, and you start off getting pleural effusions where you lose the angle here, but you can also go on to get pericardial effusions if it's really, really bad and it's due to heart failure. But yeah, pleural effusions is the big one. There's a nice slide for those of you that didn't know that. Okay, and then if we go back to shock and what Arnav taught you the other day, so what are the four big causes of shock? So hypovolemic, so if you're dehydrated, if you've lost blood, yes. Cardiogenic, if you've got pump failure and you can't perfuse all of your organs. And then some of you've gone with neurogenic, and neurogenic, anaphylactic, and septic all come under this big category of distributive shock. So it might be due to vessels being leakier than before, in sepsis and anaphylaxis, or it might be due to a lack of descending control. Obstructive shock is very important. What are some big causes of obstructive shock? Yeah, cardiac tamponade. What else? Tamponade is the biggest cause. Yeah, pulmonary embolus, that kind of thing. What is the most common ECG finding in a pulmonary embolus? Pneumothorax is also one. Yeah, sinus tachycardia. And what is the most specific sign for pulmonary embolism on ECG? S1, Q3, T3. I love how everyone just knows that. It's just such a dumb thing that is barely a real thing, but everyone knows it. Okay, and in terms of pulmonary embolus, so you say you've got a patient with a PE and you've done an ABG. What findings are you likely to find metabolically? What's the metabolic picture? Yeah, respiratory alkalosis because they're hyperventilating. Yeah, that's the most likely initial finding, depending on how large the embolus is. So if it's like a big, like branch artery embolus, then they could potentially be acidotic. But respiratory alkalosis is the most likely finding. Sorry, that was a bit of a tangent. Okay, so those are like the big causes of pre-renal AKI. Renal AKI is split into like, so I like to split it into glomerular and then other vasculature and then interstitial, but I feel like people would prefer this. So you can have problems with the glomeruli and the tubules, or you can have a problem with the tissue around them, the interstitium. Glomerular nephritis is really long and really complicated, but like important things for you to know about is diabetes, which I won't cover today, and we talked about microangiopathic hemolytic anemias that can occlude the glomeruli and cause problems as well. That's how HUS and TTP can cause renal failure. So vasculitis is technically glomerular nephritis, but we'll talk about it briefly because I find it really interesting. And you have acute tubular necrosis. With the interstitium, you can have infections, trauma, but the important thing is to know about this thing called acute interstitial nephritis. And knowing the difference between this interstitial nephritis and tubular necrosis is quite important, and it's useful to not get those confused in an exam. So acute tubular necrosis is where you have necrosis of the epithelial cells, as you can see, and this can be caused by ischemia or toxins. Does anyone know any toxins that can cause this? Yeah, gentamicin. So what class of antibiotic is gentamicin? Yeah, it's an aminoglycoside. So it's not just gentamicin. I think any aminoglycoside can cause it, but it's the most common culprit. What other toxins? So NSAIDs are not. So NSAIDs cause interstitial nephritis, not tubular necrosis. But yeah, good guess. Yeah, myoglobin. In what situation are you worried about myoglobin? Yeah, rhabdomyolysis. And remember that like a classic exam scenario for you is someone is on a statin and then they're started on like clarithromycin or another P450 interaction occurs and then they get like rhabdo, and then they'll present with like an AKI and they're like, why has he got an AKI? Compartment syndrome can cause rhabdomyolysis indeed. As someone said earlier, IV contrast is a very common cause of acute tubular necrosis. Anyone with lowered kidney function, you need to be careful of giving IV contrast to. And if we talk about one slightly weird poisonous cause, does anyone know? Yeah, lead, because lead just does everything. It's great. And there is a very distinct finding if you were to do urine microscopy for a patient with acute tubular necrosis. Does anyone know what this image is showing? Yeah, so these are muddy brown casts. And if we go back for a second, that's because red cells can leak out of the tubules and they get damaged on the way out by the kind of gaps that they're exiting through, and you get like these casts. This is a really important thing to know about acute tubular necrosis. You don't tend to get those in anything else. Okay. So vasculitis in the kidney. There are 4 main types of vasculitis that affect the kidney. Granulomatosis with polyangiitis, which used to be known as Wegener's, and then the others on this slide. We'll talk about each of them briefly. So what is this? So this is a saddle-shaped nose that could very well be due to Wegener's, but there are other causes of a saddle-shaped nose. Does anyone know any? Because like it's not actually pathognomonic. Yeah, so cocaine is cut with a drug that can cause this often. Like, yeah. Any other causes? There's an important septal infarct due to trauma. Yeah, that's probably the commonest cause of this. Yeah. What else? There's an important infection that can cause bits of your body to fall off. Leprosy is a cause of this, yeah. And then there's another autoimmune condition that affects cartilage around your body. So septal hematoma, secondary to trauma, if untreated, can cause necrosis, definitely. Marfan's is unlikely to cause this, but it could happen. It's unlikely though. Also, Marfan's is not autoimmune, remember. It's one of the congenital connective tissue diseases. Relapsing polychondritis is the other one. You don't need to know a lot about it, but it's basically autoimmune destruction of cartilage around your body. So other places it would affect are classically the outer ear. Fine. So in the context of this is Wegener's. C ANCA positive mainly affects the respiratory tract and the kidneys. Features are AKI, saddleness, and these upper respiratory tract symptoms are super important. And they often precede anything else. It's also a cause of a mononeuritis multiplex. What does that mean? It's quite an old-fashioned term. So a mononeuritis multiplex just means, oh yeah, exactly. So you've got a single nerve neuropathy in many different locations. Yeah, exactly. Multiple mononeuropathies. So you might have like the femoral nerve in your leg and then the musculocutaneous nerve in your arm. Like it's just like really random nerve involvement. What is the commonest cause of that in the world? Does anyone know what condition is the commonest cause of that in the world? Yeah, so diabetes is the commonest cause. It's one of the microvascular complications of diabetes. Precisely. That's granulomatosis with polyangiitis. So what is this triad? I told you medicine is just triads. Just lots and lots of triads. Yeah, so this is EGPA, which is also known as Church-Strauss syndrome. P ANCA positive. They get lots of weird, unrelated symptoms. Renal failure is actually pretty uncommon in this one, but it can happen. There was a patient last year at UCH who presented with like giant cell arteritis type symptoms and then had like a mononeuritis multiplex in the right arm and left leg and then went blind the next day, and they missed it because of this. It's just a really random condition. This is a lot more common than the Wegener's is. Fine. And then the last one we'll talk about is like Goodpastures disease. You have anti-GBM antibodies, which are against collagen type 4 in the basement membrane, characterized by pulmonary hemorrhage, AKI. So what is this patient going to be complaining of when they come in? I mean, they might not be complaining, they're going to be super unwell. What's their presenting complaint going to be? Potentially. Yeah, hemoptysis will be their presenting complaint. And this is a super serious condition. They will deteriorate very quickly. So you do plasmapheresis, get rid of these antibodies, and you immunosuppress them. So in the notes for this, what's the difference between P ANCA and C ANCA? So it's peripheral versus central. You don't really need to know the difference. You just need to know what conditions they go along with. So C anchor only goes along with Wegener's pretty much. Like, it doesn't really go along with anything else. But P anchor can go along with lots of things. Can go along with Church-Strauss. It can go along with primary sclerosing and cholangitis. So like, it's just know the core, like which conditions they would be elevated in or present in. Yeah, you don't need to know like the biochemical difference. Yeah, it's cytoplasmic versus perinuclear. Oh yeah, it's the other way around. Yeah, that's exactly what it is. You don't need to know that. You just need to know what conditions they go up in. And so like there's another condition that's associated with Goodpastures. It's where they don't have any basement membranes to start off with. Does anyone know what that's called? So there's a congenital lack of these basement collagen type 4. Yeah, so it's Alport syndrome, and you should read about that. I'm not going to talk about that now, but patients with Alport, if they have like a renal transplant, they can get Goodpastures because they haven't been exposed. They produce antibodies against the collagen type 4. But yeah, read about it. It's quite interesting. Fine. And then we'll talk. And then there's acute interstitial nephritis, which is just inflammation of kidney, the kidney interstitium. And you can split causes up into drugs, infections, and inflammatory conditions. So what can you think of any drugs that would cause this? Someone mentioned them earlier. Yeah, so beta-lactam antibiotics definitely can cause this. NSAIDs can cause it. Yeah, what else? There's one of the anti-tubercular drugs. Allopurinol can cause this. Yeah, one of the anti-TB drugs can cause this. I didn't mention it when we talked about TB, though. So rifampicin can cause this as well. Yeah, exactly. And then infections, hantavirus. This is all you ever need to know about hantavirus. It causes an acute interstitial nephritis. I don't think it comes up anywhere else in the curriculum. And any staphylococcal infection, especially if it becomes a bacteremia, can cause it. And then you have all the other inflammatory conditions. So what kind of inflammatory conditions cause acute interstitial nephritis? Yeah, lupus causes absolutely every single thing in the kidney. Like, if you are unsure about anything in the kidney, the answer is lupus, and you won't be wrong. Sarcoid can cause it. Yes, sarcoid can commonly cause this as well. And sickle cell is not an inflammatory condition, but I have a feeling sickle cell causes something else in the kidney. Let me check. Sjogren's syndrome is the other one that commonly causes it. Yeah. So sickle cell kidney involvement. Yeah, so sickle cell can cause like a nephrotic syndrome type picture. I don't think it's due to this though. I don't know what the mechanism is exactly. I might be wrong though. Sorry. So related note, what does this picture show? So this is one of the few histology questions that came up in our exam last year. It is not crescentic. This is not actually, this is not the kidney tubules. Yeah, this is a granuloma. This is a granuloma, and when you see a granuloma, you always need to ask yourself one question. Yeah, that's exactly what you're going to ask yourself. Is it caseating at the center? Is it necrotic at the center? Can you see any gaps in the middle? In this case, you can't. Therefore, this is a non-caseating granuloma caused by sarcoid. Yeah, sickle cell nephropathy. Yeah. Thank you for posting that. That's really useful. Can you see the slide yet, or is your internet still broken? Can everyone see this, the granuloma slide? When do you see a caseating granuloma? Does anyone else want to answer that question? Yeah, tuberculosis. And remember, like, the agon complex is the combination of a caseating granuloma in the lung and a caseating granuloma in the lymph nodes. So yeah, tuberculosis is the biggest cause of a caseating granuloma. What other conditions can cause non-caseating granulomas if you were to think about the rest of the body? Yeah, so Crohn's disease classically causes a non-caseating granuloma. What would it look like if it was caseating? Let me post a picture in the chat. The center would look necrotic, like you'd be able to tell. What's the origin of the term caseating? Here's a pub quiz question for you. Caseous like cheese, yeah, it's like cheese like necrosis. There's a picture. If you can see, there's just a massive like hole in the middle of that granuloma. It's just not very regular. Can you tell? It's not very obvious, but like I think you can tell if you look at it. That's fine. What other things can cause non-caseating granulomas? So we've spoken about like two inflammatory conditions. We've spoken about sarcoid and we talked about Crohn's disease. What other like groups of conditions can cause? So lupus doesn't usually cause granulomas. So leprosy can cause granulomas, and I think they tend to caseate more often than they don't. But yeah, I think lymphomas are another cause of non-caseating granulomas. But again, if they get big enough, they can caseate as well sometimes. But yeah, most of the time though, if you see a caseating granuloma, it's tuberculosis, and if it's not a caseating granuloma, it's quite likely to be sarcoid for your exams anyway. All right. So that's renal AKIs, excluding glomerulonephritis. What's the last category? So post-renal AKI, yeah. And how do we split that up? So this is the same way you'd split up post-hepatic jaundice. So how did we split up post-hepatic jaundice? Is the chat frozen, or is no one answering? Ah, yes, someone answered. Yeah, luminal, like mural, and then extraluminal. So like, remember, every time there is an obstruction in the body, you split it up into these three things. Is it in the tube, is it in the wall of the tube, or is it something on the outside pushing in? So luminal causes problems within the tube that cause an obstructive acute kidney injury. So the tube in this case, in case anyone didn't get it, is the ureter coming out of the kidney. So yes, stones is the commonest cause. What else? There's one other thing you can get within the lumen. Blood clots, exactly. Stones and blood clots. We're not going to talk about clots, but we'll talk about stones for a minute. And then, what problems can you get within the wall of the ureter? So yeah, you can get cancer, or you can get strictures. And when are you concerned about stricturing? Or like, what kind of history would the patient have if you were thinking about stricturing? What are they quite likely to have in their history? What's like a common cause of stricturing? It's an iatrogenic cause. It's something doctors do. So surgery, it could be surgical. It could be surgical scarring. What's more likely than surgery? So catheters could cause it as well, actually. Yeah, but yeah, in these patients, especially in female patients, it tends to be due to radiation. So if there's tumors and stuff around there, and you do radiotherapy, they get strictures due to the radiotherapy. So that's like quite a common cause. Okay, and then yeah, you get. Do you know what kind of cancer you get within the ureters? What kind of cells you get cancers in? Yeah, so it's urothelial cells, which are transitional cell carcinomas. Yeah. So remember, transitional cells have the ability to switch from epithelial to columnar based on certain like local conditions. Okay, and then extraluminal causes. There's three big ones. Two of them are the same as yeah. So lymphoma and enlarged lymph nodes. Yes, that's one of them. BPH or prostate cancer is another big cause, and then there's one slightly weird cause. There's one strange fibrotic cause, which is called retroperitoneal fibrosis. Yeah, exactly. Sorry, I got to it first. And retroperitoneal fibrosis, you see like strands coming off the kidneys on a CT scan. You don't really need to know about it, but yeah, it tends to occur with some inflammatory conditions and some cancers. But the big causes for you to know are prostate cancer or benign prostatic hyperplasia. That's super important, especially, I mean, only in men. Okay, and then so we'll talk about stones. So renal stones cause renal colic. What does colic mean? Yeah, so colic is just pain that comes in waves due to this. It's like the waves of smooth muscle contraction. Yeah, exactly. The tube is pushing, but there's something stuck within it, and it's rather painful. So investigations. What investigations can we do for stones? CTKUB is like the gold standard, but what would you do before you got to the CTKUB? So I think that ultrasound is something that they can use, but they don't really use it. And like CTKUB is a lot more sensitive and specific nowadays. Yeah, so you do a urine dip. It's a simple bedside test, and you also culture it. Always remember to do some blood tests, your FBC unis. You want to check how long they've had the stone and whether it's given them an AKI. And you do a full blood count and an ESR because you want to know why did I put ESR? You do a CRP. ESR is a bit old and you only use it in inflammatory conditions, but like you're doing it because you're worried in case there's an infection overlying the stone. There is one bacteria that classically is associated with renal stones. It's a cause of UTIs that is associated with renal stones. Does anyone know which one it is? Yeah, Proteus mirabilis. I just remember it because it sounds like marble and stones are like marble's a stone. But yeah, that's a commonly implicated bacteria when it comes to renal stones. And then management, you have like 4 options. Does anyone know what they are? So pain relief and is going to be your first line treatment, and NSAIDs are the best form of pain relief for stones. Then, as in definitive options, what do you have? So you have lithotripsy, which is where they shoot shockwaves at it and break it up into smaller pieces, and then it will pass out on its own, hopefully. Yeah, what can you do if that doesn't work? Or it's slightly too big for that? Yeah, so you have like a couple, before we get to surgical, there's one other thing you can do. I mean, if if it's small enough, you can just wait for it to, if it's less than 5 millimeters, they usually just wait for it to pass on its own, so they don't do anything. So PCNL stands for percutaneous nephrolithotomy, I'm presuming, is one of the surgical options, and then the other thing is called a ureteroscopy. So the difference between these is one of them you go through the skin, and the other one you go up the urethra. But those are your options, and depending on the size, you do different things. The percutaneous nephrolithotomy is used specifically when stones are really big and stuck in like the renal pelvis. So if you have like a stone in the renal pelvis and it started going up into like the little angles of the kidney, so it's never going to pass out. So you might need to use like a percutaneous intervention. But yeah, that's management of renal stones. So that's everything I wanted to talk about, actually, in terms of AKI, except for this little useful acronym that you should definitely remember. Anytime a patient is in AKI, you stop diuretics, any angiotensin-related drugs, metformin, but only if the GFR is below 30. If it's not below 30, and they will give you exam questions where it's between like 30 and 45, you can continue doing it, and you might just reduce the dose. And NSAIDs. But do remember that any drug that is renally cleared will have an increase in concentration during AKI. So what kind of drugs would you be worried about, and would you think about reducing the dose of in AKI? Or rather, categories of drugs? Yeah, so the important one, that's the one I was hoping someone was going to say, is digoxin. Digoxin is renally cleared. In AKI, the concentration of digoxin goes up massively. It's going to cause arrhythmias and they might die. Diuretics, you're gonna hopefully just stop. As a junior doctor, you would just stop. Kidney doctors do lots of weird stuff to get stuff to work. And lithium is another cause that you don't need to know about in fourth year anymore, I think. But yeah, lithium, you would also reduce the dose of. What is the important kidney side effect of lithium? This is the last question, promise. So it's not nephrotic syndrome. But yeah, it's diabetes insipidus, nephrogenic diabetes insipidus, to be precise, yeah, which means it doesn't respond to giving vasopressin analogs. Yeah. Okay, so those are all the questions and slides I had for today. So I left some time in case people have other questions about other things. So I'll stick around for a bit. Can I just ask you guys to fill in the feedback form before you leave? And if you have any questions about anything, just drop them in the chat. No problem. I'm hoping people preferred the shorter session because the feedback was the sessions were a bit long. There is the link to the form. It's the same form. If you fill that out and let us know what you want to cover next time. Also, if you prefer this format. I'll stick around for another 5 minutes if anyone has any questions. For renal, what is the most common things that we need to know for exams? So the two most important things to know in terms of renal are acute kidney injury, because that's the most relevant bit of renal to like general medicine, and chronic kidney disease and what we can do about it. So renal replacement therapy, renal transplantation, that kind of thing. Those are the really important things for renal. Glomerulonephritis is like super niche. It honestly doesn't come up that much. Or you just need to kind of know which one's caused a nephrotic versus a nephritic syndrome. But yeah, renal, you don't actually need to know that much for your exams. No worries. Do the questions on PastMed reflect exam questions, or is it better for revision of content? Yeah, so this is like a thing that, like I say to everyone, PastMed questions are great for learning content. They're very they like asking about buzzwords. They're quite straightforward cases in terms of their one-step answers. So they're great for learning content, and you'll find them difficult when you start with them. But like when you get closer to your exams, you'll find that other sources of questions are usually a bit more reflective of UCL. So assess and progress is a bit harder than UCL exams, I think, but is more reflective of the style. I'm not sure if you know the difference between like one-step and two-step questions, but the thing is, PastMed is like these are the findings on examination. What is the diagnosis? That's a one-step question. UCL questions are more like, these are the findings on examination. Given the most likely diagnosis, how would you treat this condition? That's what UCL questions tend to be like. So assess and progress is quite good. I used QuesMed fleetingly last year. I used it like for a bit before exams. I think it just asks lots of very, very niche things. And like some of the questions are good, but like I think it's like way nicher than UCL exams are. Yeah. Ahmed loves PastTest. So PastTest is like, it's not just SBAs, it also has some like other multi-choice. It has like some other short answer questions and stuff. But he like loves it, and he's like, it's quite good to break up the monotony of SBAs. Are renal stones something we need to know for fourth year, or is it more fifth year urology? You should know what we talked about in terms of renal stones. Like they are quite, you need to know them in the context of AKI, which means you need to know like the basic management. Renal stones are like pretty important, even from a renal perspective. Which other sources would you recommend? Yeah, so I think PastTest is quite good as well. From what I've heard, I know a lot of people use that. Osmosis videos are really good for revision. Any online resources, the med school post. When it comes to like, when you get closer to your exam though, assess and progress is like the closest thing you'll get to your exams in terms of style. And there's like a star ranking system within the book, so it like you can avoid the stupidly difficult questions that won't come up, or you can do them because they're quite interesting, and they're still learning points regardless of difficulty. There's also like Hugh Bainan also has an SBA book that is it has a lot more rheumatology than will come up in your exams, but I think has really good explanations of things as well. I can't remember. There was another book that I think Rithika told me about, that's written by like a reg who went to UCL, that's quite good as well apparently. So there's a few books, like, yeah, I know people don't like books, but yeah, there's a few books as well. Cool. Any other questions? Would you also suggest stuff from the amnesty? Of course, I completely forgot, but yes. So all of the histology questions that came up in our exam last year were in the amnesty. So the people who'd done them got like, there were like 4 questions and they got all of them right. Yeah, it's really frustrating that they use stuff from the amnesty because it's so poorly disorganized and there's so much like unreliable content in there. But yeah, you should probably try and have a look through the amnesty as well. I guess you guys have time. Yeah. I'd also like last thing. I know that you don't have an OSCE, but like studying together in groups and like teaching each other things, a bit like how I'm doing for you, is still quite a useful thing to do in terms of learning. Like me and my firm used to do this last year, and it's quite good because teaching people is like the best way of remembering things yourself. So that's the last thing I'll put in terms of suggestions. Right, I'm going to stop recording. I think that's all the questions. Right.